I am a breast cancer surgeon, and I have the blessing every day to work with breast cancer survivors, working to create survivors by doing their breast cancer surgery, doing their counseling, and just getting them through. As many of you on this call know, can be quite a challenging time. But I think we're in an exciting time where there are so many advancements. Biomarkers can be quite confusing. So you can see here, just as you all as patients are a little confused about which terminology do we use, we're also confused. And this is really emerging technology, which is really exciting. Biomarkers is really just a big category where we're looking at genes and proteins of the cancer cells. Then there's something called genomic markers or genomic testing. And that's where we can look at genes in the cells. And what we're trying to do is really predict the behavior of the tumor. Not as easy as it sounds, but we're trying to get there. And then, of course, we're all familiar with genetic markers and genetic testing, where we're looking at the genes, not only of the tumor, but of individuals, where we can try to determine who may have inherited disease, can determine, what the disease process is going to do. Everyone's familiar with BRCA1, BRCA2. Those are two of the most studied genetic markers where we know if someone has BRCA1 or 2, they're going to get breast cancer. They're at about a 90% risk for getting breast cancer, a 65% risk for getting a second breast cancer, and about a 45% risk for ovarian cancer. So that information is valuable because that can help not only guide treatment, but we can help use it for risk reduction as well. We run tumor markers on all tumors. So we run the estrogen receptor, and that's rated, you'll see on your pathology report, from 0 to 100%. There's the progesterone receptor, and that's rated from 0 to 100%. And what essentially these are, I call them little grabber sites that are on the surface of the tumor cell that allow the cell to bring in estrogen and progesterone into the cell. And many cells can use these estrogen and progesterone that we all have in our bodies all the time. It can use our own hormones as their food to grow and to multiply. And so, as we know, there are medications that can be used to help block those receptors. So once someone's treated with breast cancer, we can block those receptors so that if a tumor cell decides to form in the future, we can try and block that process from happening and try and lower that risk of that tumor coming back in the future. There is a third item that you'll see on your pathology report, and that's called the HER2/neu. HER2/neu is not necessarily a grabber on the cell surface, but it is associated with the cancer cell. And usually you'll see the rating on the report of a 1+, a 2+, or a 3+. 1+ is what we call completely negative. 3+ is what we call positive for HER2 expression. And so those patients are going to get a medication called Herceptin, and I'll go to that in just a moment. And then there's the HER2, what we call equivocal. It's kind of middle of the road. It's not really negative. It's not really positive. And then we as the clinicians are like, well, what do we do now? So the next thing we'll do is run a second confirmatory test called a FISH. And it's either going to be amplified, which means it's truly positive, or it's going to be non-amplified and mean that it's actually negative. When the HER2 is positive, those patients are going to get, in addition to any other treatments that they get, a medication called Herceptin. And what it is it's a laser-focused medication that goes, it's almost like a video game. It goes and finds those cells that have the HER2 positive expression and literally destroys them. Medications like Herceptin have really been a game changer because a HER2 positive tumor can be considered a more aggressive tumor. But because the treatments are so great now, we can really control HER2 positive tumors a lot better than we could in the past. So then we look at genomic tests, and these are something that have come out probably over the last 20 years or so that really help us to get more information. Yes, we know the ER. Yes, we know the PR. Yes, we know the HER2 status. But what does that mean? We know that there's additional information in the cells that we can't get on a pathology report. that we can use that information to help guide treatment. So 3 of the big tests, MammaPrint, Oncotype DX, and Decision RT are 3 tests. I'm going to walk you through those. So the first test I'll walk you through is something called a MammaPrint. And what the MammaPrint does is it looks at 150 different genes in the tumor cell to try and get information on, is this a high-risk tumor? Is this a low-risk tumor? The nice thing about MammaPrint compared to some of the other tests are that this can be run on all tumor types, whether you're estrogen positive or negative, progesterone positive or negative. Even if you're HER2 positive, you can get the MammaPrint test done. It's run ideally on the biopsy specimen, which then means we can get that information very early on before we even start treatment to help us to guide treatment. Should it be surgery first? Should it be chemotherapy first, something known as neoadjuvant chemotherapy? We can get all this information, and that really helps us to design the treatment plan for that patient. You heard Michael talk about personalized care, and so it's these genomic tests that really help us to really personalize the care. The other thing this test can tell us is, will the patient benefit from extended hormone therapy? Most people will get hormone therapy for about 5 years, but there's some people who would benefit 10 years. And so this test will give us that information so that the oncologist can have a conversation with the patient. And there's a test called an Oncotype DX, kind of similar to a MammaPrint. This runs on 21 genes, and this was one of the first tests that was available. One of the limitations when you compare this with the MammaPrint is that it only can be run on tumors that are ER positive or PR positive. It has to have that progesterone or estrogen receptor in order to run this test. The other cool thing about this test is that you can run it when someone has positive lymph nodes, up to 4 positive lymph nodes. This can help to give us information. And what this test tells us is, does the patient need chemotherapy or not? So the higher the score ranges from 0 to 100. The higher the score, the more likely that you are going to get a benefit from chemotherapy and that you are going to get a reduced risk of recurrence over the next 9 to 10 years. So if we know that today and we can try and say, hey, in the next 10 years, you have a high risk of recurrence, chemotherapy is going to be advantageous for you, then that is a lot of great information that you know. On the flip side, if you have a lower score, this will tell us that you have a tumor that is probably has a lower likelihood to recur in the future. So then we may not give you chemotherapy. We would opt to do, hormone therapy in addition to any surgery and or radiation. And then the last test I'll review is something called the Decision RT. This is only for DCIS patients. There's been a lot of talk in the literature about DCIS. Is DCIS really a cancer? Is it an early cancer? Is it a precancer? Again, us as clinicians are still kind of debating this, and there's a lot of emerging data that's coming out daily about DCIS. And so the big question is, well, if it's so early and it's usually stage 0, do these patients need radiation? Are they going to benefit from it? Just like we want to know, is somebody who has an invasive cancer going to benefit from chemotherapy? So we can run this test, and this test will give an answer to determine if the patient will benefit from radiation, and radiation is used to help lower the risk of that cancer coming back locally in the breast. Or they get no benefit, which then means these patients can forego radiation and then be followed, usually with their hormone therapy, getting their mammograms, and just be followed that way. And then that just eliminates that risk of radiation, which does come with some risk, but radiation also does a lot of good. So the goals of these types of tests, and hopefully there are new things emerging, it really gives us more insight into the tumor biology compared to just looking at the estrogen, progesterone, and the HER2 status. And this really guides us into more precise, individualized care. And the result is patients have better outcomes, and we know how to monitor these patients in the future. Are these patients that we need to keep a hawk eye on because they're at higher risk for recurrence because of the results of these tests? Or are these patients who show that these tests show lower numbers? And yes, we are still going to follow you, but we know that your risk of recurrence is going to be low. So it's really exciting. I hope there will be more of these type of tests that come out, just to give us more information and insight so that not only can we do better as clinicians, we can provide better care to you all as patients.